All right. We're a couple minutes past the hour, so let's begin. My name is Lisa Sipenko, and I head Consilium Scientific. Last month, we started a new theme at Consilium, talking about cancer and Alzheimer's, and today is the second event in the series focusing on drugs for Alzheimer's and whether oncology provides a template for discovery. And we have a distinguished panel of speakers for you today. So we're welcoming Professor George Perry from University of Texas, and we're welcoming Professor Rudy Tanzi from Harvard University. We're welcoming John Lazo from University of Virginia and Professor John Hickman, who is on Consilium Scientific's board and this cancer discovery professor from University of Manchester in the past. So our speakers will give their own introductions and the statements. So I am asking the audience to participate with their own questions. You can put your questions in the chat, but preferably you raise your hand and we give it you an opportunity to ask a question. Otherwise, we prepared a fascinating discussion for you and we're ready to start. So I would like to welcome Professor Tanzi to introduce himself and state his position on the subject.
Well, thank you, Lisa. So I've been at Massachusetts General Hospital and Harvard University my entire career, from student to professor. So that's a long time. In my own career back in the 80s, I was one of the groups that discovered the amyloid gene. I named it amyloid precursor protein, APP. I was on the nomenclature committee, so I get to name it. And in 95, discovered with Peter Hislop and Jerry Schellenberg, the other two early onset Alzheimer genes, the presenilins. And the presenilins make the enzyme that cut APP. APP is the substrate for amyloid. So the first three genes basically said it was involved with production of amyloid beta. And so I've dedicated much of my work on understanding how amyloid beta causes Alzheimer's disease. And what I've learned is amyloid causes this disease very early. It triggers the disease, but treating amyloid in a patient isn't going to do much good. Kind of like treating cholesterol in a patient with heart disease. You had to treat cholesterol early. So I'll just end by saying that more recently in 2008, we found the first neuroinflammation Alzheimer's gene as part of the Cure Alzheimer's Fund Alzheimer's Genome Project. That was CD33. And that taught us that microglial cells, innate immunity, and neuroinflammation plays a key role. And there, I think if you want to help patients suffering now, you really have to stop neuroinflammation, which is causing most of the cell death. But to prevent the disease early on, prevent the triggers, you have to hit amyloid decades before the disease. And that's basically what our work is based on in terms of drug discovery and development.
Thank you very much, Rudy. George, please.
Yes. Thank you for inviting me here today. I've been studying Alzheimer's disease probably a similar period to Rudy. Both of us have been in the field about 40 years. And in terms of my own studies, probably what I'm best known for is oxidative stress, metabolic imbalance during the disease. Also doing work, which I'll talk about later, about how amyloid plays a critical role in the disease, but depending on where it is, as Rudy has said, it either can play a protective role or it can play a pathological role. And how is this related to cancer? When there's the obvious things of cell cycle reentry, which happens during Alzheimer's disease, but happens for sort of the opposite reasons. And then you come down to the treatment paradigm, which I think we'll pursue as we go along, using biomarkers, the role of the environment in the disease, and also the fear of the disease. Both cancer and Alzheimer's disease strike a lot of fear into people and patients. And is it justified, or is that fear actually creating more problems?
Thank you, George. Very important social aspect. So John Lazo, please.
So I'm John Lazo, formerly trained as a chemist and as what I call an eclectic pharmacologist. I spent almost all of my career in academia for about the same period of time as George and Rudy. Almost all of that was focused on oncology, but I call myself an eclectic pharmacologist because we've had research programs in leishmaniasis, in pulmonary fibrosis, and acute lung injury, as well as Alzheimer's disease. And I think one of the biggest problems that we have in science, in fundamental science, is the, excuse me just a second here, thought I turned that off, is siloing of researchers. So the cardiovascular researchers go to cardiovascular meetings, the neuroscientists go to the neuroscience meetings, cancer individuals go to the cancer meetings. And so I think one of the important aspects of today's webinar is our ability to communicate between two very important areas. And with respect to the thesis of the whole meeting, I think that we can certainly, in the oncology field, learn from the Alzheimer's community, and from the Alzheimer's community, they can learn from our mistakes and our successes in oncology.
Thank you, John. John Hickman, please.
So I think I'm going to win the competition for how long we've been in the field. So in 1971, I started a postdoc in cancer pharmacology. And I went to a meeting in 1971 where the only thing that we knew about cancer was the metabolism of glucose was thought to be different. This was the Warburg effect. And that was it. Really, we knew nothing else. And it's been amazing in the last 50 years to really see the changes that have occurred in a molecular understanding of cancer and its consequences, both in terms of biomarkers and, as we'll discuss, the discovery of drugs. I started as a chemist and was pretty reductionist. And as I've aged, I'm becoming less reductionist and understanding the complexity of pathology. And in cancer, I think that's taken us a while to really understand this is a very complicated disease, and we still don't understand all the biology. There is still unknown unknowns. And one of the fundamental things that changed our lives of most of that 50-year period was the discovery of mutations and chromosomal changes that provided biomarkers and then genes. But now we're thinking again about it because actually all of us are carrying mutations in KRAS or other oncogenes, but we don't get cancer. And work from the 1950s that I wasn't aware of, I was too young, showed that inflammation was very important, promotion. And so I think there's a shift that we might want to discuss from what's the trigger to the environment that trigger then generates to generate the pathology, and how we address that in terms of drug discovery. So that's my 50 years worth.
Thank you. Thank you so much for the introductions. I'd like to start this discussion with more of an overview of where we are right now with cancer. And John, you really started drawing this picture, what has happened over the last 50 years. And no one can deny that we made incredible successes in cancer. Some cancers are indeed curable. There are very, very clear clinical benefits of science advances. And also there's incredible percentage of failure when it comes to what we tried to do with conquering cancer and where we didn't succeed, going down wrong models, wrong pathways, spending a lot of money, including a lot of people in clinical trials. And we have Alzheimer's, where we don't have clinical successes so far, but we're embarking on that path, on that journey, which potentially is full of these very similar mistakes they may lie ahead. And that's why hopefully today's discussion can highlight some of these potential paths. So the question for John Lazo and John Hickman, what is your feel, just personal individual perspective based on the work you've done or your knowledge of the field? Are you happy where we are with cancer research and successes? Could we have done better, or that's pretty much naturally where we're supposed to be?
Well, Lisa, let me say that the real successes in cancer therapy have been in hematological disorders. If you look carefully at the successes that we've had with solid tumors, it's a little less successful. And I think, part of that relates to the disposition of hematological disorders versus solid tumors, microenvironment issues, the complexity associated with that. I believe that to some degree, the oncology community has perhaps overemphasized the success. And we also are very treatment oriented. And as John Hickman and I have discussed on numerous occasions, getting to the disease earlier, either in a prevention format or with better detections, I think is very important and very relevant to the Alzheimer's approaches of the future.
Thank you. John, any comments from you?
Well, yeah, it kind of dismays me that there's a 96% failure rate in drug discovery in oncology. And as you said, that costs a terrific amount of money. And I think that comes from a lot of people not accepting the complexity of the disease, of the late stage disease. So the most important poster child in cancer was for chronic myelogenous leukemia. That was the discovery of a drug called Gleevec. So that's targeted to a tyrosine kinase, and those people do tremendously well, and they would probably die with something else. But that really isn't a cancer. It's a single translocation, BCR-ABL. And once that hematological cancer goes to blast phase and gets unstable and complicated, that drug doesn't work. And I think the problem with our field is that we've hung on to the Gleevec poster child, and we've reached, in my opinion, I think we've reached with targeted therapies to oncogenes, I think we've reached a plateau. We haven't mentioned immuno-oncology, and it's been fantastic in some diseases. And 50% of people with melanoma respond brilliantly and can live for years. But we don't know why. We haven't got the biomarkers. So I think with respect to targeted therapies, I would say that we're on a plateau. I think one of the things that we might want to talk about is models. I think the models of cancer are far too reductionist. They don't capture the complexity, and that's why the drugs fail. I mean, you can see stacks of preclinical data that look brilliant, and then the drugs don't do anything. And that says that the preclinical data, the models, are invalidated because they don't work in the clinic. So I think that we're still struggling to a certain extent.
So that leads me to another question where, as you say, cancer is recognized as many different diseases based on genetic and epigenetic changes, and treatments need to be different for different types of cancers. So the question to George and Rudy, are there multiple forms of Alzheimer's disease? Can you talk us through the basics here?
I think that's something that's being promoted now is heterogeneity. But so far, in terms of treatment, there hasn't been treatment even for genetically linked Alzheimer's disease. None of the therapies have worked any better. So I think it's probably both heterogeneity, and we've been hitting the wrong target at the wrong time.
Mm-hmm.
Yeah, I might push back on that, George. I think that the current drugs that are approved are not optimal. They're expensive and they're not very safe, but they do clear amyloid. The big problem
But the clinical
is,
benefit is very minimal.
yeah, if I could finish. So if they do clear amyloid, but optimally, you need to clear amyloid before symptoms hit. The elephant in the room is that we don't diagnose Alzheimer's disease until the brain has already deteriorated to the point of dysfunction. If we diagnose heart disease the same way, we'd wait till you have congestive heart failure to give you a cholesterol drug. If we treated diabetes the same way, we wouldn't give you insulin until half your pancreas beta cells were gone. This is the elephant in the room. This disease begins 10 to 20 to 30 years before symptoms with amyloid deposition. The genetics, the brain imaging data, biomarker data says amyloid triggers this disease early, the way cholesterol triggers heart disease. Just like you can't take someone who needs a bypass and make them better with a statin, you can't take someone who's already been diagnosed with Alzheimer's disease and make them better with an amyloid drug. And George is correct. In those trials, you take these early stage patients who are just turning the corner into dementia and cognitive impairment from pathology that started decades ago, and you're taking away their amyloid, and they get this marginal decrease in cognitive decline. They go downhill 25 to 30% more slowly. No one's going to even notice that. But it provided some proof of concept that says we need better drugs, repurposed drugs that are safe and affordable. So in 50 million people in the US alone, 50, who have amyloid in their brains right now, but don't yet have symptoms, but are on their way, we can nip it in the bud the way we do with cancer, heart disease, and diabetes. Early detection that amyloid's starting to accumulate, and then get rid of that amyloid before it drives too many tangles to form and too much inflammation. Finally, I just say it's really inflammation that leads to dementia. George has been on this his whole life. Oxidative stress, you and Mark Smith, they were correct. What gets you to inflammation in Alzheimer's disease is the deposition of amyloid, which is inducing tangles, which causes cell death. That combination is slowly inducing microglial activation, inflammation. And when you have enough inflammation, and only then do you lose enough synapses and neurons to get the disease. So for patients who are suffering right now, hitting their amyloid is like blowing out a match with a forest fire blazing. You got to put out the forest fire. You have to have drugs that hit inflammation. So it's a very different strategy for prevention after early detection, tackling the plaques and tangles, the match, the brush fires, versus a patient with a wildfire of inflammation going, well, you have to put that fire out. We have to see that that's a difference in treatment versus prevention.
But isn't it true that the proportion of patients with amyloid will never get cognitive impairment? And as you say about inflammation, is it possible to find those patients with
Where do you get
amyloid?
that from? No, that's not true. There's no data that says most people with amyloid don't get cognitive impairment.
So
no,
all
that's
people-
not true. That's not true. There are people with abundant amyloid, centenarians, and do
Well,
not
yeah,
have cognitive loss.
Well, come on, if there are not that many of them, let's be honest.
I
If you
know
look at
there are
super
not that
ages,
many
centenarian-
centenarians.
Right, there are rare people, resilient people, who have amyloid and tangles. And I study them. I have whole genome sequences on 100 of them, and another 200 super age or centenarians. What we see in them is always the same. Plaques and tangles, but resilience at the stage of inflammation. Somehow their microglial cells and astrocytes stay chilled out. And in the presence of plaques and tangles, they don't have the neuroinflammation that causes enough cell death and synapse loss to give you the disease. And it's very rare.
There's a recent study that was published in PNAS, and it's with an animal model, which always has its limitation, and done by Chris Wheeler, in which they genetically modified the inflammatory system with T cell inflammation. And they ended up creating in mice with normal genes, amyloid plaques, and tau accumulations, suggesting that inflammation can, in some cases, be a more primary change.
Well,
So
this is
it's
a public forum,
probably a
so
positive feedback system. Pardon me?
it's a public forum, so I don't want to criticize a paper, but there's never been a mouse that has made amyloid with its own genes.
That's what this one is.
I know. I read the paper again.
I wrote a commentary on it.
Okay, that's probably not worth arguing about.
But
So where are we now with the prevention? Because the new drugs which came out recently, they are looking at mildly symptomatic patients, and you're suggesting that we should be going in completely asymptomatic patients decades before, right? Is anyone looking into these populations, and what so the focus is to really detect people who have mild amyloid buildup?
Yeah, I think this is extremely risky without understanding amyloid's role in the disease. It's hard to know if it's causing things or it's a response and not a passive response. We have data which Rudy has done some similar studies suggesting that it plays an antioxidant role.
Yeah, A beta has a role, not amyloid.
Yes.
Amyloid beta protein, it's a host defense peptide, as we've showed.
Yes.
It helps quell long-term potentiation. It works on vasoconstriction. Amyloid beta is not junk. The monomer, once it's induced to form amyloid, that stuff is dangerous. It then induces tangle formation and neuronal cell death. And tangles are part of innate immunity too. They prevent viruses from spreading. We would argue that all of Alzheimer's pathology evolved as an orchestrated innate immune host defense for the brain. Now we live too long and it turns against us.
Yeah, I agree with you.
I think to say amyloid's not causative when you have gene mutations that guarantee the disease by 60 in the substrate for amyloid precursor. Then you have mutations that guarantee onset of the disease by 60 in the enzyme gamma secretase, the presenilins, that cut that substrate to make amyloid. Then you have the most common risk factor, ApoE, that determines how fast you clear amyloid from the brain. I don't see how we can hide our head in the sand anymore and say amyloid is the trigger, the cause of this disease early on. But if you treat amyloid by the time we diagnose Alzheimer's today, which is too late, it doesn't help. You have to prevent amyloid early on. Brown and Goldstein got the Nobel Prize for studying an early onset family with heart disease, guaranteed, yes. And it was mutations in LDL receptor, and it implicated cholesterol. But they didn't say, oh, that's okay. If someone needs a bypass, just give them cholesterol drugs. Early onset, fully penetrant familial disease mutations tell you what to prevent: cholesterol and heart disease, amyloid and Alzheimer's, not what to treat once you already have the full devastation of the disease.
So my understanding is people with heart disease are treated with cholesterol reagents even after having problems. Sure. And the cholesterol deposition is not the only piece, because cholesterol reduction by itself is insufficient. Right. But it's also part of the inflammatory response.
We're saying the same thing, George. Cholesterol deposition over time is going to cause enough inflammation and damage to get heart disease, congestive heart failure, need a bypass. And Alzheimer's, if you only have plaques and tangles, the resilient brains show us that's not enough to get the disease. Plaques and tangles alone will not give you Alzheimer's. They trigger inflammation, and then only after inflammation do you get enough cell death and synapse loss to get the disease. So no wonder that in GWAS and the whole genome screens for new Alzheimer genes, 100 new Alzheimer genes, 66% of them are innate immune neuroinflammation microglial genes. We found the first one in 2008, CD33. So it all comes together.
So if you look at cancer, and going back to my comment about chronic myelogenous leukemia, where there's a translocation, if you look at asymptomatic people at all sorts of ages, they've got that translocation, but they haven't got the cancer. So there's a parallel there. There's a trigger, and then something else has to happen. The problem in cancer, and I'm not sure, if this is a positive piece of news that could happen in Alzheimer's, the problem in cancer is that it's evolving. It's got genetic instability. And once you try to target it, it becomes incredibly reactive to that targeting. And there's plasticity in the tumor itself, and then there's changes in the microenvironment that are incredibly complicated. And that's certainly the case with advanced cancers. So the limits that I talked about with targeted therapies and the problem with the models is that they haven't modeled that real complexity. And I really had a question about Alzheimer's. I mean, if you've got genetic stability there, maybe that's going to be quite positive, because in cancer, you've not got that genetic stability, even very early on. Chromosomal changes are found in ovarian cancer, for example, in very young women who get ovarian cancer 30 or 40 years later. So, this is a huge problem, this genetic instability and a Darwinian evolution. I mean, is that what you see also in Alzheimer's?
Let me just throw one more thing out there, John. You don't get resistance to beta blockers. You
Yeah,
don't get
yeah.
most drugs. In cancer, it's always the case. So I'll throw on top of that, Rudy, do you think as we begin to approach therapy for AD, will drug resistance emerge because of, even in light of the fact that maybe there's not as much genetic instability as there is in cancer?
I can't answer that. I mean, the drugs we need to prevent this disease need to either turn down the production of amyloid early on in life, decades before symptoms, or clear amyloid. The two approved drugs clear amyloid quite well, but they're not particularly safe. They're expensive, and you can't use them in 50 million people who need them. You couldn't afford to do that, plus the safety issues. But repurposing drugs, and back to the topic of this webinar, repurposing cancer drugs, I think holds great promise for hitting the neuroinflammatory component of Alzheimer's disease. We invented Alzheimer's in a dish, where we can recreate through neurons in a 3D matrix, a mini brain organoid, neurons making amyloid. We showed it that as the amyloid accumulates, it causes tangles to form, real tangles from endogenous tau protein. We can block the tangles if we stop the amyloid. And if we have microglial cells enter the mix, then you induce microglial activation and inflammation. And then most recently, and this goes along with George's comment about T cells, I agree T cells are very important, and the Wheeler paper is very important for that reason. And David Holtzman's recent paper, that when the T cells come in, they make inflammation 100 times worse. So I like to say amyloid's like the match that lights the brush fires of tangles that spread. But if that doesn't induce the wildfire of inflammation, you don't get the disease. So if you look at the cancer drugs that came up in our screen, we screened all of the FDA-approved drugs and 3,500 natural products to say which ones hit this temporal course of disease. If it takes 10 to 30 years in a patient to go from amyloid to tangles to inflammation to dementia, in the dish it takes 6 weeks. And I would say that in many of the hits we have, from nilotinib to masitinib, dasatinib, and quercetin, that we can hit neuroinflammation in the dish quite well with a lot of cancer drugs. And some of them actually also induce the microglial clearance of amyloid, just like the 2 new approved Alzheimer drugs go. So I think repurposing to get to drugs faster, to start giving people a chance to prevent disease after you now have a blood test for amyloid, is going to be the way we end Alzheimer's disease. Early detection, early intervention, safe repurposed drugs, and do it as soon as possible.
Rudy, you've made this connection genetically between amyloid or amyloid pathway and increased Alzheimer's disease. And you talk about inflammation, but we find, and other people have found, that most individuals over the age of late 40s onward have some form of amyloid in their brain. And they also have some forms of inflammation.
Mm-hmm.
And those are part of the biology of normal aging.
Mm-hmm.
Could it be that that amyloid is a critical element of the aging process, and it plays a different role, one role when you're a normal individual in aging, and then plays a slightly different role after disease onset?
Yeah, I actually think, to be honest, I think that I agree with you what you're saying, but I think that amyloid and an amyloid-inducing tangles is part of aging. And if we live long enough, most of us will have amyloid and tangles, and inflammation.
Well, you don't have to be particularly old.
No, but inflammation, as soon as you have amyloid, you're going to start getting exhaustion of microglial cells. So you're going to get activation and start getting inflammation. Yes, and oxidative stress. And amyloid itself can induce oxidative stress, as you and Mark Smith showed ages ago. So these 3 events of amyloid, tangles, and inflammation, they are concurrent early on, decades before symptoms. But the genetics says that you can start with amyloid alone to get to tangles, to get to inflammation. And that it does take decades of accumulation of these pathologies before you have enough cell loss and synapse loss to get to disease. So I think if a patient has Alzheimer's right now or early stage, and you had to give them a magic drug, stop the inflammation. That's the only way you're going to help them. But to end Alzheimer's disease, I believe now that it's clear, the faster you make amyloid, the sooner you get Alzheimer's disease. So know early on that amyloid's coming. Hit it early with primary or secondary prevention and nip it in the bud, and you will not get the tangles and inflammation following, and you stop this disease and end it.
Rudy, the difference with cancer, of course, is if you have early detection, you can cut it out. So what do you do in Alzheimer's?
If you have early detection that amyloid's starting to accumulate in the brain, which we can do now, not with just PET scans, but with blood tests that are very good for amyloid detection, you would provide drugs. I'm working on what's called a gamma secretase modulator for many years now that would turn off the amyloid production, hopefully safely. But other drugs you can use will get amyloid to be cleared from the brain. We can do that with, we learned from exercise that the muscle hormone irisin goes into the brain after you exercise, turns on the enzyme neprilysin that enzymatically clears the amyloid. We know that the gut microbiome, as we've shown, can induce microglial cells to clear the amyloid. There are other mechanisms to get amyloid exported out of the brain. The brain's going out of its way to figure out how to get rid of amyloid, from enzymatic degradation, microglial uptake, export out of the brain. All of these things can be pharmacologically addressed. And I think rapidly with repurposed drugs, including some cancer drugs that come up in these screens. And the faster we have a cocktail of safe drugs that get rid of your amyloid and turn down production, as soon as you need to do this, primary or secondary prevention, you start to nip Alzheimer's in the bud and end it. So that, just like we hit cholesterol to stave off heart disease. It's perfectly analogous.
So I don't want to preempt another webinar from Consilium, but we've got one coming up on cancer prevention. And actually, it's a discussion of the economics of that and how you do a trial on prevention, which pharma is certainly very reluctant to do. And the state, certainly in Europe, European countries, is kind of reluctant to do because it's very long term and very expensive. So that's the first point. The second thing, that's preventative trials. The second thing is early detection. And the great worry in cancer is the false positives. And you talked, George, about, the stress. So a big discussion in cancer is you tell somebody they've got a KRAS mutation and they're likely to get melanoma. And that's got a huge impact. So I wondered how you saw that in the case of Alzheimer's. How do you run prevention trials? And how do you see early detection where you can have false positives?
I think that's...
Go ahead, George.
I think that's a big concern. Rudy identified some of that, like exercise. The main benefits for Alzheimer patients that have been shown inconsistently is lifestyle modification, which I know Rudy adheres to better than I do. Exercise, dietary change, reducing stress, all of which probably plays a major role in reducing inflammation and changing amyloid beta clearances. Is pharma going to support this type of research? Well, the government supports most of it in foundations.
Well, we just published a lifestyle intervention trial with Dean Ornish last month that astounded me. I mean, I never expected it to work. It was only, 50 patients in 20 weeks. They had a vegan diet. There was meditation practice, monitored their sleep, exercise, online interaction, and not only did folks go downhill more slowly using the same cognitive tests that were used in the newly approved Alzheimer drug trials, but by some tests like the CDR Global, some of the patients got better. And a lot of this had to do with a high fiber, whole foods diet that allowed the gut microbiome to help the brain clear amyloid and reduce neuroinflammation. Now you were asking about biomarkers, John, and there are biomarkers, blood-based biomarkers, that can tell us if you have plaques and tangles, and they benchmark really well against imaging. I'm not so sure I'm worried about false positives there as much, because if you do the blood test and you do want to start a certain drug that might be expensive for getting rid of your amyloid, you can do a scan to confirm the blood test, and I think that would offset the false positive rate. So I think we're a little better off in that regard.
But just like in cancer drugs, there's the chance of adverse reactions. And there's two of them. One of them is that all of these drugs that have addressed amyloid cause brain shrinkage for everybody. And whether that's good or bad still hasn't been addressed, because some people think it's shrinking because it's changing inflammation. The other thing is some people have a vasculitis that is fatal. Most of those are ApoE homozygotes.
But that's for the immunotherapy, and I'm not condoning that. You know, immunotherapy, what happens is these antibodies to amyloid, if they bind to the vessel amyloid, cerebral vessel amyloid, that causes a local edema and swelling, and it can also cause a microhemorrhage, which in most cases are reversible, 99% of times reversible. That's why they do MRIs with that immunotherapy to see if that's happening, so you can stop the treatment and reverse it. But that's not optimal. First of all, immunotherapy is too expensive to use on 50 million people who have amyloid right now. You need something cheap and safe. And that's why I think repurposing drugs for that purpose, and even natural products, and emphasizing lifestyle is how we get there. To say, you know, early on in life, do what you have to do to keep your brain safe from inflammation and amyloid deposition and that whole cascade.
And what you're saying has been what's been so successful for heart disease. There isn't one approach. There's lifestyle modifications, cholesterol reduction, surgical intervention, etc. For Alzheimer's disease, and I don't know how this has been with cancer, it's been that there's going to be one magic bullet.
No.
And I don't think there's going to be one magic bullet. It's going to be a whole range of modifications.
You really have to hit all three pathologies at the right time. Amyloid deposition, the tangle formation that is driven by amyloid. And again, you can get tangles from head bangs too. Oxidative stress can lead to tangles. So you can get a vicious cycle. This goes back to your work, George, where amyloid might induce tangles and the cell death induces inflammation.
Mm-hmm.
Oxidative stress from inflammation comes back around and induces more amyloid, which would explain the paper you mentioned earlier from Wheeler, that inflammation can get you to amyloid. So you get a vicious cycle: plaque, tangle, inflammation, amyloid. And you got to interfere with that. You need a cocktail to do that. It won't be a magic bullet. But hopefully that cocktail will be safe, affordable drugs to democratize early detection and early intervention, not just expensive immunotherapies that only the very wealthy might be able to buy off label.
I think your comment about the magic bullet is a good one, because if my skepticism about the anti-cancer drugs over the last 30 years is there, it's because there was a belief, as I said before, about a magic bullet, and it's far too complicated. So I actually see cancer going in the same way as you were discussing in Alzheimer's. We've got a situation at the moment where you've got colon cancer in 20-year-olds. And we're beginning to see the impact of pollution on the rise in lung cancers. This is in non-smokers. And that's to do with the environment. And again, it's to do with Western diets, the lack of fiber in the case of colon cancer, inflammatory bowel disease leading to colon cancer. So I think this shift from a reductionist magic bullet sort of approach to cancer, which is taking place, and moving towards prevention and early detection, despite some of the challenges with early detection, is the way that cancer will go in the next decade. I don't know if John agrees.
No, I agree. And I think one of the places where the Alzheimer's community can perhaps benefit from the oncology discovery experience over the last 70 years is it's axiomatic that we treat cancer patients with multiple drugs. And so this whole concept of combination chemotherapy, which drug do you give first? Which drug do you give later? Do you give them simultaneously? Do they both affect the same pathway, or does one affect a different driver or passenger mutation? Could be very helpful in the design of repurposing drugs or taking new drugs and applying them toward Alzheimer's disease. And I know Rudy's been thinking about that pretty carefully.
Well, we have
Yeah.
300 over the last 7 years, thanks to Cure Alzheimer's Fund, and John, you're on the board of that amazing foundation. We've been able to screen all approved FDA drugs and 3,500 natural products and validate. So we have over 300 now identified that either stop the amyloid from inducing the tangles. Some of them just stop amyloid deposition. The ones I'm most excited about program microglia so that the microglial cells are more likely to eat amyloid and clear it versus getting exhausted and senescent and going into a pro-inflammatory state where they release pro-inflammatory cytokines and chemokines and induce neuroinflammation. And I think those drugs, which we're testing first, the first clinical trials we do will be cocktails of drugs that stop the glial cell inflammation because that's what patients need. That will not only help prevent the disease. Like if you had a drug that got a microglial cell to stop causing inflammation and go back to housekeeping and eating amyloid the way Leqembi and Kisunla induced them to do, you get 2 for 1. You get the microglial cells to stop hurting you and begin helping you again by clearing amyloid. So the cocktails, so we have cocktails of drugs, and many of these are cancer drugs that came up on our screen. It was agnostic. And so I think reprogramming microglia, energetically, they need more ATP to clear amyloid than when they're exhausted and they just say, okay, shoot out cytokines and cause inflammation. You have to reverse that. And I think that's where the great hope is for repurposing drugs is in microglial reprogramming.
How confident are you, Rudy, about the models? Because we've had, advances in models, preclinical models in cancer, and organoids have been there for now about 15 years. And it's not changed a lot. They still really don't capture the complexity of the disease.
No, the organoids don't capture the complexity, but the mouse models stink. I mean, they just make amyloid. For a long time we argued, and George was part of this. We said, oh, how could amyloid be causing Alzheimer's if the mice don't make tangles? Well, now we know the mice can't make tangles. They have the wrong tau protein. We were fighting about nothing when it came to the mice. Now there are mice that have been humanized that they make tangles in response to amyloid. They have to have the right tau protein. But and the other knock against the amyloid was, well, we wiped out amyloid in patients that didn't get better. And I say that's like taking people who need coronary bypasses and saying we dropped their cholesterol and they still need a bypass. You have to do
I don't agree with you. I don't agree with you completely, Rudy, because these people were very early in the disease. Some of the people, like the woman that died at Northwestern, was essentially normal. She was an ApoE homozygote, so she was at risk, and she didn't improve.
If you're,
there were thousands of patients.
Yeah, but if you're mild cognitive impairment, early stage Alzheimer's, you've already gone the whole gamut.
She wasn't even in mild cognitive impairment. She was practicing law. Although maybe to be a lawyer, you could have MCI.
Then why was she getting treated? I don't know if she wasn't a patient.
Homozygote, ApoE.
Then how could she get better if she wasn't sick? I don't understand.
Anyway, okay. The other point that there are no cases in which people really improved by having amyloid removed. John Hickman, you made a very good point about the environment.
But it's not enough, yes.
What is that?
You do admit that removing amyloid, and I'm not saying, I don't recommend this as a therapy, but in those, let's say, proof of concept, very expensive trials that Eisai and Lilly did.
Yes.
By removing amyloid in the earliest stage patients, they significantly slowed cognitive decline, even though it was only 25 to 30% slowing, which, your spouse isn't going to notice.
There's been some question about the way this is calculated and the dropouts, et cetera. But 25% is not a big change.
Right.
But I want to go to the environmental issues that you've addressed with your work with Ornish, is that there's a lot of work now showing that air pollution has an effect. Caleb Finch, actually at USC, has argued that Alzheimer's is a disease of modern society.
Yeah, we actually co-authored that.
What's that?
Finch. I said we co-authored that paper with Tuck Finch a couple of weeks ago, where we showed, but you know what we showed, and you're not going to like this, is that we can induce Alzheimer's with air pollution in these mice, but we used our gamma secretase modulator that turns off A beta, and we made them better. So it's still
great.
Yeah. The air pollution nanoparticles act as seeds that nucleate amyloid. If you turn off the A beta 42 with the gamma secretase modulator, then you you basically neutralize the effects of air pollution on the brain. That's what the
Well,
studies.
that's a parallel with cancer. So in those cancers where pollution is important, there's an EGFR, epidermal growth factor receptor, mutation in those people. And if they live in the countryside, then they don't get non-smokers lung cancer. If they live in a polluted area, they do. So that was a major paper in Cancer about lifestyle and the environment. So I think that is a really important thing, and it's interesting to see if there is a parallel with Alzheimer's. And there was John Lazo sent me an article last week from the Wall Street Journal, where they coined the phrase inflammation, aging, I think it was. Is that the word? You know, that all of us become inflamed as we age.
Yeah, that word's been around for a while, but but it was, I was actually quoted in that article a lot.
You were quoted right at the end, Rudy. Yeah, I saw that.
Actually, beginning in the end, and they wouldn't call me Dr. Tanzi because the Wall Street Journal will not call you doctor if you have a PhD, I found out.
So should we all be taking our aspirin still?
Well, you know, it's the inflammation, the NSAIDs and aspirin trials have not worked. I mean, it's not enough for the inflammation in Alzheimer's. I think you really have to address the details of microglial activation. Microglial cells are the linchpin because the microglial cells are first to respond to the amyloid. They're first to respond to the tangles. They try to housekeep and do a good job. But when they encounter bits of dead neurons and synapses, these are called DAMPs, disease-associated triggers of inflammation, okay? They are programmed to still assume that when they're engulfing dead neurons, there's an infection. So whether there's an infection or not, this is called a kind of a sterile inflammation. They stop clearing amyloid and housekeeping. They become amoeboid. They take in their ramifications, and they shoot out pro-inflammatory cytokines and chemokines and induce astrogliosis and inflammation. Then and only then do you get Alzheimer's disease. But the trigger that converted the microglial cells to become killers was the plaque and tangle, and that process takes decades.
It's like Lisa wants to say something.
Yes.
Yes, I want to ask you two questions, and we have a lot of questions in the chat, and I wanted to invite a couple of people to ask a few questions. So I'll be quick. My two questions for you. If we're talking about those 50 million people who may need an intervention to benefit in the future, can you in a couple words describe who are these people? Are these asymptomatic 40-year-olds, or who are these people? And the second question, I know you explained a couple ways we can consider going forward in terms of potential therapies, and hopefully we find something non-toxic, cheap to use, a cocktail of drugs. How do you see, based on the current understanding of biology, I know we don't have enough empirical evidence, based on current understanding of amyloid clearance, is this something that you take this intervention for a symptomatic person for X number of weeks, months, a year, and you stop? And then you monitor the person? Or is this something like a statin that you kind of should be taking for life? Pharma will make you take it until. So where are we with that? And then I'll give a word to Francois to ask questions. He put a lot of good ones in.
So I'll try to answer quickly so we have enough time. So the 50 million people, that's the estimate that comes from folks who do brain imaging, and especially on normal elderly folks, or starting even at 50 plus. And you basically calculate how much of the population already has amyloid in their brain. The later you have amyloid in your brain in your life, the less likely you're going to have Alzheimer's, because you're going to die of something else before that 10, 20, 30-year course is going to get you through tangles and spreading and cell death and inflammation to the point that you lose enough synapses to even have mild cognitive impairment. So ApoE4 carriers make amyloid earlier in life. So by, let's say, 40, 50 years old, you're starting to get amyloid. They need help. They need safe, affordable drugs to bring that amyloid down. Now, how long do you take them? Well, if you're clearing amyloid and the drug is safe enough, take it the way you take a statin. The drug I'm developing to lower production of amyloid, the gamma secretase modulator, not inhibitor, but modulator, that could become, we believe, like a statin for Alzheimer's disease. If it's safe enough, if you know you're at risk for amyloid more than others, like an E4 carrier or some of the other genetic factors, you might just take that drug like a statin your whole life, assuming it's safe enough and it's affordable. That would be the goal. So I think you wouldn't just do like the immunotherapies where you clear it and say, okay, we're done. If it's safe, affordable drugs, especially repurposed drugs, then you would, if you know you're predisposed to amyloid, you would just keep taking it to turn off the tap and unclog the drain, turn off the production and clear the amyloid out as needed throughout your entire life, assuming it's affordable and safe enough.
I think
That's our goal.
I think what you said is really critical, that they have to be affordable and safe.
Yeah.
And the antibody treatments are much like chemotherapy, but where you have a drug that's very expensive with a lot of potential side effects, etc. And my understanding in cancer treatment, when you use those chemotherapeutic agents that have a lot of adverse reaction, it's usually late phase in the disease. If you're going to start treating 50-year-olds, that even if they develop the disease, it's a decade away, you really have to have something that's incredibly safe.
I agree.
Thank you. I'd like to give a word to Peter for a quick question, and then we go to Francois, and then we'll wrap up. Peter, please go ahead.
Thank you, everybody. I'm not sure this is a quick question, but there are lots of problems facing the world. I would argue the climate crisis is probably the greatest threat to people with dementia and people with cancer, for example. How do scientists, and this is the middle part of our conversation of 3 sessions, as you all know, and Lisa will tell you about the third one next, play a role in the discussion about social priorities? Because how much energy should we put into what kinds of drugs? We've laid out here several ways of intervening through time in relationship to other things like air pollution. And I would argue that lifestyle gets overrated. We ought to be making public health interventions that allow us to lead healthier lives and not depend on individuals. So I've just listed half a dozen things. How do scientists responsibly participate in social discussions where we have to make decisions about how to prioritize helping people with both cancer and dementia?
So Peter, are you asking, first of all, it's great to see you again, Peter. It's been a long time. Are you asking how can scientists take more of social responsibility to motivate individuals to live healthier lives to reduce their risk?
Not necessarily, Rudy. That could be part of your answer, and I would appreciate that. It's more the issue that there is increasing focus on science being brought into the public sphere, whether it's around climate or whether it's around health. Scientists have their own agendas. We've seen that, and that's appropriate. But in the social space, we need scientists to be speaking up, helping policymakers and citizens make decisions, not just about lifestyle, but about allocating resources in general. So that's why it's not an easy question. I mean, my answer is we ought to be engaged, and we ought to be cautious about too much focusing on our own priorities and more on being citizens.
Sure. You know, I was asked to testify to Congress a few years ago to basically, there was an opinion that if you had genetics that predisposed you to Alzheimer's or brain-related neurodegenerative diseases, that you were sunk. There was nothing you could do. And so I had to testify only 1 to 2% of the known mutations associated with Alzheimer's cause the disease with certainty. 98% of genetic variants are such that lifestyle makes a difference and you can offset that risk. And they wanted me to testify so that they could think about agendas for exactly what you're saying, to more forcefully bring to people the knowledge that your lifestyle matters more than your genetics for offsetting these diseases. I don't know if anything came from it, but at least they were thinking about it back then a couple of years ago in this testimony.
Peter, very important comment. So thank you so much. We're running out of time. So if our speakers need to disconnect, please do go ahead. And I'd like to give Francois a word. You put a lot of very interesting questions. So Francois, feel free to ask what you want to ask. combining all your questions.
Thank you, Lisa. I really wanted to thank you, particularly Rudy, George. You have given a lot of fantastic information, fascinating. I have a slightly more, let's say, I would like to play the devil's advocate, if you don't mind. With the anti-cancer treatments and with the treatments with Alzheimer, I'm wondering where we should put our expectations. My impression is that we are probably hitting a wall with these products. So in other words, we might treat some diseases, particularly dementia of Alzheimer type, but it will not eventually have any effect on the life expectancy of the people on the population. So my question is, where shall we put our expectations? Do you think, Rudy, George, that these products in the future could potentially improve the survival of the patients in addition to their quality of life over a short term? So what could be our expectations?
I think the key is prevention, Francois. You have to not wait until the brain deteriorates and then diagnose Alzheimer's and try to bring it back. And that's just doesn't work. But if we can detect the early changes that are leading to this disease, just like we look for cholesterol and coronary artery disease before you get congestive heart failure, that if we can prevent this disease early in someone in their 40s or 50s, so that they're still fine cognitively in their 60s, 70s, and 80s, I think that's more of the goal than waiting until the brain deteriorates and then trying to just make the best out of their lives until they die of another cause.
Wait, Rudy, even if now the cause of Alzheimer is well identified and preventative measures primary prevention measures are fairly simple to implement and they are not completely implemented. So what would be our expectations in terms of success of these lifestyle changes or prevention measures?
Maybe we can learn.
Yeah, George.
I was just going to say, people saying about cancer is more advanced stage in terms of treatment. What has for solid tumors? What has been the advancement with treatment in terms of survival?
Well, that's that's one of the problems. I mean, you're seeing what's greeted as a great success, providing just months, which to a patient and the oncologist is significant. But we're not seeing cures.
Because that's where we are right now with the amyloid approach,
right.
Maybe months.
Yeah. So if you have if you take lung cancer that's not complicated and has an ALK translocation, you can get 3 to 5 years. Once it gets complicated and it's a normal non-small cell lung cancer, you're talking about a few months. And we haven't got time to discuss it, but I wondered what your expectations was. I mean, I just have a final comment on what I agree with you about the prevention, but in the UK, certainly, there's a discussion about wokeism. One member of a political party said, "You'll be telling us what to eat next." And, if you can't get people to wear a mask in the United States, well, good luck, huh?
On that note, I have to end the conversation and the fantastic discussion. Thank you so much. Looks like it was part 1, and there's so many questions and comments in the chat that I wish we had time to cover it. But huge thank you for Rudy and George and John Lazo and John Hickman for finding the time to join this conversation. In December, we have a 3rd event focusing on the FDA and what's been going on with Alzheimer's products. But with drug discovery and possible ways to prevent the really difficult diseases and to help people, there's a lot of work to do. So good luck with your research. Thank you so much for your expertise, and we'll see everyone in about 2 weeks. Thank you.